Good evening and welcome. I'm glad to be here with everybody this evening to discuss one of the most important topics of our time, the opioid epidemic. My name is Jessie DePonte and I'm the Executive Director of the Coalition for a Better Wallingford. Our coalition is a grassroots movement created by two parents, Ken Welch and Jen Short, who lost their daughter to drug use. After Taylor's death, Ken and Jen realized that Taylor was one of many drug-related deaths right here in Wallingford. Wallingford is not the only town to struggle with opioid use and death. Since 1999, more than 760,000 deaths have occurred from a drug overdose. Of those deaths, 2 out of 3 deaths involved an opioid. It was estimated in 2019 that 9.7 million people aged 12 or older misused prescription pain relievers. We are delighted to partner with the Wallingford Public Library for this event. You guys are awesome.
You guys are awesome.
The One Book, One Wallingford book this year is Transcendent Kingdom by Yad Ayasi, which focuses on many topics, including the use of opioids and addiction. The protagonist, Gifty, is studying neuroscience at Stanford to learn more about addiction. Like many in this country, Gifty has a deep connection to addiction and mental health, as her brother died of an overdose after getting addicted to Oxycontin due to an ankle injury. Gifty's story is a story that is played out throughout this world. Tonight, we hope to shed some light on this crisis in depth from different perspectives. We are honored to have a wonderful group of panelists with us this evening, so I'm actually going to pass the microphone down and ask everybody to introduce themselves and tell us what organizations they're from.
Welcome. I fully endorse the book if you haven't read it. It's worth reading. I'm Craig Allen. I'm the medical director at Rushford and the chief psychiatrist at the State Medical Center. I'm John Ellison, psychiatrist and an addiction medicine doctor, and I am the vice president of addiction services for the Behavioral Health Network of Hartford Health.
Hello, my name is Sergeant Brangi. With the Wallingford Police Department, supervise the community impact unit for about 17 years. And in that community impact unit, there is 5 people within that division. A couple of them are school resource officers, and the other 3 primarily that the patrol doesn't do and are kind of head towards what's actually issues are going on that are time consuming, that doesn't require immediate response from the patrol division and a more intense investigative
Hello, Officer Zelikowski, I've been part of the department for over 7 years now. Spent some time in the patrol detective division and
And Ernie?
Hi, my name is Ernie Mrazik. No, you don't have to do that, but thank you, Doc. I've been a pharmacist in Connecticut since before most people in the audience was born. But anyway, around 2008, I got involved in being a public speaker to certain civic groups, SCOW, etc., about substance abuse. Because during the 90s, it was the Percocets and the Oxycontins of the world that people were either getting it from a doctor or from their family medicine cabinet or from friends. And this is when you first started seeing the prescription, at least abuse. In 2013, I had joined the Coalition for a Better Wallingford. I'm currently a vice president and medical liaison for the coalition. And I'm also a part-time pharmacist at Gaylord Hospital. Thank you.
Wonderful. Thank you so much, Ernie. So tonight I kind of want to focus on 3 different topics within the opioid epidemic. First, I want to talk about the medical aspects of opioids and the specifics of OUD, opioid use disorder. Then I would like to talk about the impact
I'm having, ask him again, we're having some
Oh,
audio
we're having
issues.
some audio problems.
Yeah, go ahead and ask.
All right, Ernie, hopefully you can hear me. My first question is for you. During your time as a pharmacist, Ernie, how have you seen the use of opioids evolve over time?
This whole issue, especially prescription drug abuse, began based on a letter to the editor of the New England Journal of Medicine in 1980. And it was a Boston collaborative program that studied 11,800 patients who were giving at least one dose of a narcotic pain reliever and who had never been, subject to addiction. And only 4 patients were addicted, 1 severely. So they came with the conclusion that addiction was not considered a major issue with narcotic pain relievers. And this quote, 5 sentences, 161 words, was picked up and used as a marketing message by Purdue Pharma and when they launched Oxycontin in 1996. So the crisis really arose in the mid-90s when physicians were told the risk of addiction was low and the opioids prescribed for chronic pain. Because previous to this, most opioids were used for like cancer pain, end-of-life care, stuff like that. So, nationally, we lost 100,360 people last year, and in Connecticut, 1,372 in 2020. So, some areas are doing better than others. And of course, the big threat now is fentanyl, cheaply made in Mexico with precursors from China, and a little 2 milligrams, enough to fit on this little pencil, lead, is a fatal dose. So that's how powerful it is. 100 times more powerful than morphine or 50 times more powerful than heroin. So, anything else you want to?
No, that's great. I know that we most recently in Hartford, we saw fentanyl in the schools, and that resulted in some deaths, which is really alarming and terrifying. So thank you for chiming in on that. My next question is for Dr. Allen. Often OUD starts with a legal prescription, which can then turn into addiction. What steps have been taken in the medical field to try to decrease potential addiction?
So it was data from 2009 that was used in a CDC-sponsored event here in Wallingford, because in 2009, Wallingford and Minnesota, 2 little cities here in Connecticut, had among the highest rates of opioid overdose deaths in the entire country. And Tracy Green came down here from Brown and ran this rapid assessment and mobilization, which came up with recommendations, fast and implemented, which are the same types of things we are struggling with today, including naloxone, education, and a lot of them have been, we're still struggling with deaths. Naloxone distribution was one of the things on that list back in 2009. And as you mentioned, what is it now? That at the Sports and Medical Sciences Academy in Hartford, 3 kids have used fentanyl in school, and a 13-year-old died. And the Monday after that incident, I met with over 200 parents from that school to talk to them about what fentanyl is and how kids get it, the accessibility in the schools and in the community, which is really the point. That we were dismayed and sad, but should have been surprised, saddened but not surprised that it found its way into school.
particularly in the city where opioid overdose deaths had increased so dramatically in the non-Hispanic, Black, and Hispanic populations. Prior to 2020, the Caucasian population had the highest rates of opioid overdose death. 2020, the non-Hispanic Black population outpaced the Caucasian population. 2021, more than 1.5 times the rate, the opioid overdose rate in the population. And for the first time, Hispanic population rate of opioid overdose death superseded that of Caucasian. The population at the school.
Sorry.
Oh, you turned it off. I can't talk if this isn't. The population at the Sports and Medical Sciences Academy, about 68-70% color. Oh, there it is. So the rates are really, really high in the community. It's important to know what's going on in the community and to be prepared. And this is not, I mean, there's many schools in Connecticut and beyond that do not have training in signs and symptoms of opioid overdose and do not have naloxone on site. And that school is, at Hartford Public Schools, did not have naloxone on site or their training. 2 weeks later, there was another incident at a school in Connecticut where a 16-year-old presumed fentanyl overdose in school, did receive naloxone, did live. So some of the things that came up in that rapid assessment and were recommended have been done, but not in a comprehensive way across our state. So there's a lot more work that we can do. You asked me the question, what are we doing in the medical field to try and address the risk of opioid misuse, opioid addiction? And there's a number of different things that have gone on since 2011. Changes in the law, changes in the requirement that, and Ernie knows about this as a pharmacist, the requirement that medical prescribers of controlled substances like opioids, so Oxycontin, Vicodin, and so forth, they're required to check a site, a prescription monitoring program. It's a website that identifies whether the patient that they're going to prescribe to is getting a controlled substance, and also included in there now is medical marijuana, whether they are receiving that from another doctor, a prescription that's been filled somewhere in the state. And you can also Google nearby state. Google. I said Google. You can also check. You can't Google it. But you can also check in the PNP nearby states and see if they've received someone's received a prescription there. The reason is that if you're getting multiple prescriptions, it increases your risk of misuse and drug interaction, and the possibility that you're diverting, and if you're diverting, maybe you are doing that to access some other substance. And so it allows the provider a chance to have a important conversation and explore further what might be going on. Another regulatory change is in requirements for continuing medical education for medical providers. Every 2 years in the state of Connecticut, there are a number of requirements. One is domestic violence. Another one that has come on board over the last few years has to do with pain management and safe use of opioids. Opioids have a place for severe acute pain, maybe post-surgical, maybe a post-traumatic injury, but the education that hasn't been provided around pain management and hasn't been provided around opioids and left all of our providers susceptible to misinformation, such as Ernie was talking about. The education that they weren't getting was that these medications can be useful for particular injuries and pain short-term in small doses or just enough to manage the pain. But the longer you're on these medications, and I'm talking about a month, the higher the doses are, and I'm talking about over 50 morphine milligram equivalent, which is not a very big dose. You increase your risk of developing an addiction. You increase your risk of having an overdose. And this is information that our healthcare providers did not have through the 90s. And instead, in lieu of this, they were given information by drug companies, which had motives to sell more drugs. If you guys have seen Dope Sick or read the book, Dope Sick's Netflix series, and the book is out there. I've seen a little bit of the series. I've heard it's wonderful. I mean, horrible, but compelling. The book is really good and includes what Ernie said and a lot more about how all of this evolved. One of the things that we did at Harvard Healthcare back in 2016, we started a series of risk management lectures, mandatory risk management lectures on non-opioid approaches to pain, on identifying high-risk patients. So people, some people are much more vulnerable to developing problems when using controlled substances or when using opioids, and other people might not be at as high of a risk. And this is all information that wasn't being provided in medical school, wasn't being provided in graduate medical education, and was sorely missed and desperately needed. So we started doing non-opioid approaches and safe use of opioid analgesics in Harvard Healthcare, and a number of other organizations did likewise. And the state of Connecticut actually required that as part of the yearly CMEs. So that's a jab at your question. Yeah.
Yes. Okay, no problem. No worries. Okay, so while we're doing this, I don't know, Ernie, if you had any feedback or any connections to what Dr. Allen was saying in regards to, how, I mean, that was a very thorough, wonderful answer. And I think it's really great to see that there are so many other alternatives and so many options. And it is taken really seriously, which I think is just so important. And yeah, absolutely.
There are often better options.
Yes.
And to make people aware of that, make both patients aware of that, and the education for doctors has been really important and continued to be
Yes.
really important.
Absolutely. And as part of the work we're doing at the coalition, we are actually, Ernie is the boots on the ground, as we would say. We have a grant that we're working on in which Ernie is taking information to different doctors and different sites to talk exactly about the kind of things that Dr. Allen has brought up. So Ernie has done a fabulous job for us in that we're working with the state on a grant that's been really great, and he's had some great feedback on that. So Ernie, did you want to chime in anything about the ADOPS work that kind of ties into this?
Yeah, it was the program came from our state department of substance abuse and mental health, but it came down to the Wallingford health, well, all the towns and cities, their health departments, and we were asked, it was passed on to us, and basically I went into every primary care office, oral surgeons. Primarily, that was it. And the idea was, the ADOPS stands for academic detailing. It's like you're kind of like detailing against a lot of this overuse of drugs that went on over the years, but a lot of it's been curtailed. And it's also being sponsored by the University of Connecticut School of Pharmacy. So we went into the physician's office and basically wanted to see if they were using the prescription drug monitoring program and how they were using it. And it was nice to know that Hartford Healthcare, initially they had to go on a separate site, like mostly pharmacists do, but they built it into their software. So if they were going to prescribe a controlled substance for that patient, they just click on something on the screen and it would send right into that site, so they could see, make sure the patient's not doctor shopping per se or any of that stuff, it's a lot harder today to actually for a patient to doctor shop, although some of these patients could be great actors and actresses. The issue with Oxycontin in 2007, the company and 3 executives were criminally charged by the government, and they paid a $700 million fine. But that didn't really stop them. What happens was the original 12-hour Oxycontin tablet really only lasted 9. And the other issue is addicts found out if they microwaved it, it would destroy the time release mechanism. So theoretically, if you got an 80 milligram tablet, you would get 80 milligrams oxycodone all at once. And that proved to be fatal for people who've never ever tried it, and maybe young adults and teens partying and that kind of stuff. Then along about 2010, the street prices of these oxycodone and other drugs, Vicodin was very popular, hydrocodone, got so expensive they started going to heroin. And in Wallingford at the time, you could buy a $5 or $10 bag versus paying like $80, $100 for an Oxycontin 80 milligram tablet. And then within a few years after that, what even got cheaper was fentanyl that was being cut into heroin, cocaine, and methamphetamine. And those are the deaths you're seeing now. Our statistics, and maybe the last issue, because I don't want to monopolize this conversation, but I'm so passionate about it. The statistics from the Office of the Chief Medical Examiner for Connecticut. In 2012, we had 357 deaths. 83% were opioids, and only 4% of those 83% were fentanyl. Jump forward, say 4 years, 2016, we now have 917 accidental deaths. 94% were opioids, but of that 94%, 53 was fentanyl. Now, 2020, which is the latest number, 1,374 deaths, 93% opioids, and 86% fentanyl of the 93%. So you really got to it's all about awareness and promoting prevention and the community at large, which we've been doing since the formation of the coalition.
Absolutely. And I think that's so true. The coalition mostly works in prevention work. And we think that's really important here in Wallingford. So thank you for those comments, Ernie. Ernie he sends us articles and he keeps us abreast of everything happening in the community. So we're really thankful for Ernie. Absolutely. So speaking to community, we can shift over to that vein. So joining us is Mary Mushinsky. Thank you for being here with us this evening. So I'm going to pass the mic down. My first question is actually going to be for our lovely officers. What is the protocol when you suspect a potential, and excuse my language because I don't know a potential detainee, I'm not sure what that might be, is using opioids, and do you have specific resources that are provided to that person that you can point them to if you suspect that there's something going on?
So the first thing to answer your question first, I'll go into some downs. If we suspect someone's under the influence, especially of a opioid, we're going to try to get them help from the medics. They're more trained than we are in helping them out. Our patrol units and all the officers do carry Narcan with them. So that's always with them in the cruiser. So if they were actually overdosed and not responsive, we do give that first, call the medics, because we usually get there before the medics. So we could assist in getting them better and getting them out some treatment. For specific things about the detainee, you're just looking for certain signs. We're all trained officers for advanced kind of impairment. We know what to look for people under influence of opioids. So we're basically just looking at what we could do to help them there. We're not concerned about making an arrest at that point. Our first thing is to make sure they get the help they need. If we have to do investigation, that could come afterwards. And just to add a couple of things, like as a police department, you're always looking at the most simplest thing you could do to kind of help the community. So what we've done as an agency, we've worked with the DA where they sponsored a drug take back event that we do yearly. So people could go right to the police department. It's publicized and they could go right to the PD, not even get out of their cars, drop it off at a table, and we'll have officers with some members of the organization dispose of it. That's a yearly event, but our department is always open. And if any prescription medications could always get dropped off at the front desk, as long as it's a prescription medication, we would take that and then we get it disposed of through our evidence. So those are the simplest things that we always try to do. When we do go to overdoses and issues like that, we try to kind of educate anybody who's there. So if the victim is overdosed and we're trying to give them treatment, the medics come, people who are around them, family members, friends, we always try to educate them because sometimes there's still hesitation if they should call us or not because they don't want to get in trouble, but we do remind them of the Good Samaritan Law about how that is, they're not going to be concerned about getting arrested if they're going to get treatment. And honestly, we still see that to this day, that people are hesitant to kind of contact us. Sometimes it's delayed before we get notified of it. But that is something we try to do to kind of education, stuff like that. Personally, I've been to a lot of these calls. I do have a drug detection canine. So we've been there. And our role, even when we're doing investigations in these narcotics or opioids, is try to see who's selling these things, because a lot of the drugs nowadays, they are cut with stuff, and it all depends on the price. So what they're going to try to do is cut it with whatever they could that's cheap, and the people who really think they're getting a certain type of drug are getting something else, so their body doesn't know how to take that in. So you will see the increased overdoses from that. I know, like you said, it's part of an investigation to try to figure out where it's coming from based on our interviews with people on scene. We do have a lot of sharing information with other towns, other agencies, the state of Connecticut. We're always involved in that. There's always information sharing about where these items are coming from, this contraband's coming from. And we do try to track it down to the source of it. And that is, thankfully, that's our main thing, is try to find the source of these opioids to kind of put the case against them. So that's the main thing in law enforcement, trying to disrupt that element of it. But I think that's
great.
Wonderful. Thank you so much. And we really wanted to make sure that you were represented on this panel because we realize that you guys play such an integral role and you are the boots on the ground, just like Ernie's the boots on the ground and Dr. Allen, everybody here is really seeing, and Mary too, Mary's seeing it too. Mary is so involved with our coalition. And so my next question will be for Mary, actually. So what steps have legislators taken here in Connecticut to regulate opioid use? So I will pass this down to you.
Okay, let me get the right one.
No problem.
Brought all my files. I didn't know what you were going to ask me. Okay. After I go through these, though, I hope sometime tonight I get to tell you the good news.
Yes,
Okay.
please do when you're done.
Because there is some
Please
good
do
news
share.
this year.
Wonderful.
Yeah, I was looking through the list of legislation that we've done in the past 4 years or so. And a lot of it came out of the coalition, actually. Because I remember initially when we were working on this, we were getting, some of the pharmacists still had handwritten prescriptions. That's illegal now. Everything has to be done electronically. That was how people abused one particular pharmacy in Wallingford and got excessive dosages. And somebody from your department, I think, is the one that found that out. But, you know, we did do a number as the issues came up and we discovered they were problems. We did one bill after another trying to clamp down on the illegal sources. So I'm just going to go through some of the more important ones here. We do have agreements between law enforcement and EMS providers and community health organizations to distribute and administer Narcan. That was Coalition for Better Wallingford was the first one that kept insisting that we have Narcan in all the squad cars, that we have it in the EMS ambulances, and that even family members have Narcan, because somebody could suddenly keel over in their own house and you have a very short window of time to save their life. So that was one of the laws we did in 2018. We allowed standing orders for pharmacists to give opioid antagonists, Narcan, to families. So it's not for a specific patient, but there would be a supply there for pharmacists to use for people that need them. We had a fact sheet prepared by the Alcohol and Drug Policy Council on how to deal with opioid drugs and prevention. And that was put on the state's website, on the Department of Mental Health and Addiction Services website. And it was also distributed to all the pharmacists and the healthcare providers. The electronic information portal on how many and whether they were available substance abuse disorder treatment beds. That, I remember on program review investigations when I chaired that committee, we had a hell of a time getting people beds who were in crisis. And we couldn't find out how many were available and where they were. And it was a matter of the families would get on the phone and they would just keep dialing the phone for hours trying to find a bed for their family member. That has been streamlined. So we have a portal now where you can determine where the beds are. And this stuff is all on Department of Mental Health and Addiction Services website. So people go to ct.gov and then ask for mental health. That page will come up and there is information there to help families. We classified in 2019, we classified fentanyl, which is a synthetic, as you already mentioned, synthetic version of opioid. But we classified it as a narcotic. So there are higher penalties for narcotics. And that allowed us to use more severe penalties on the dealers. In 2019, we provided information on treatment options for inmates, especially before they are released back into the community. If they serve their time, if we know they have a substance abuse disorder, at least 45 days before they're released, they have to get information on their treatment options. What we used to do in the bad old days is we would just let the person out on the street corner in their old neighborhood, and promptly they would get back into trouble. And now we're trying to steer them into treatment before they even leave the prison system.
That's something that the state of Connecticut has really championed.
Yeah.
Because the highest rates of overdose death in the state are within 30 days of being incarcerated.
Right.
So that was wonderful that the state of Connecticut could do that.
Right.
And get treatment started before people are released.
Yeah, well, all this stuff is step by step, where we first got whacked with the problem and then we had to figure out each year. What can we do this year that will make this better? And I speak to you as the reason I'm on the coalition is my own brother was an addict and he did die. And it took 5 years before he died. But I saw the whole thing. I saw the whole thing from illness to can't get a bed when you really need one to people escaping the hospital rather than checking out without authorization against medical advice. So they could go out and get another batch of drugs or alcohol. So I actually saw this myself and I was very enthusiastic to help the coalition because I've been there and I've seen it. We did a pilot methadone treatment for certain inmates and it's tied to when funding is available. And I'm going to tell you at the end, we just got an enormous pile of funding from settlement, which I'm very excited about because it's going to let us help a lot of people. We did, in 2017, we had the chief state's attorney establish a pilot program to identify and track homeless and addicted and mentally ill individuals who are in the criminal justice system and refer them to healthcare programs. Because, you know, let's face it, a lot of the folks that are in prison are there because they have an underlying mental health or substance abuse issue. And that's how they ended up in the criminal justice system. And they're really mentally ill people. That's really where they should go for prevention and for supporting them on the outside. We let nurses destroy or dispose of their patients' controlled substances. And again, we're trying to keep the unused pharmaceuticals from getting into the wrong hands. So we are deputizing certain people to allow them to do the destruction. We did Department of Consumer Protection regulations on allowing pharmacies to accept and dispose of unused prescription drugs, just like the police department does. You can go into certain pharmacies and they will get rid of the drugs for you. We required at least one EMS provider, whoever gets there first, basically. Sometimes it's the police, sometimes it's the EMS people, but whoever gets there first, they will be equipped with an opioid antagonist, and they have to go through training on how to use it. Coalition for Better Wallingford has had training sessions too, where we train how to use the applicator. And we've all been to the training. Starting in 2018, we required hospitals or EMS people that treat a patient for an overdose to report it to Department of Public Health. If you remember when the coalition first started, you could not tell why someone had been taken to the hospital. Do you remember back in those days when some very good detective work by folks at Yale and also some of our Wallingford folks painstakingly figured out who was there for an overdose and who wasn't, because you could not tell. If you looked at the intake records, you could not tell why they were at the hospital. So now there's a reporting to Department of Public Health, and the department in turn has to give the data to the municipal or district health department. And that's because we want to know where the hot spots are so that we can work directly with the local health department. The data is confidential for persons, but at least we have an idea of, you know, in this one town, we've now got 30 new cases, and in this town, we've got 64 cases, and we know where to send help. So the record keeping is really important, the data. I probably spent 4 years fighting with the insurance companies about this, more than 4 years. Many years fighting with the insurance companies to cover medically necessary inpatient detox services. People had insurance and they couldn't get their child covered, and they would talk to my committee and they would say, well, we have an insurance policy, but they aren't helping us. And I would sit down with the insurance companies and say, why aren't you helping them? And they'd say, because it's an unpredictable cost. If somebody breaks their leg, they know that it's 6 weeks and then your leg is healed. So they know they're going to be paying for 6 weeks. If somebody has a substance abuse problem, they do not know how long it's going to take. It might be 6 months, it might be a year, it might be the rest of this person's life, and they don't know. So that is why, that's basically philosophically the reason why they always fought any effort on our part to ensure parity on mental health issues, because they couldn't predict what the cost was going to be. So we've done a number of bills to require them, but to prohibit them from denying service and to require them to deal with a diagnosed substance abuse disorder. They also have to pay out of network healthcare if the person was, if the treatment was rendered in Connecticut for substance abuse disorder. We also, and again, fighting with the insurance companies, in 2019, we had to prohibit them from excluding coverage solely based on an individual having previously received a prescription for naloxone. So, because, you know, the insurance companies are looking to see if there's somebody that's a risk. And if they see you previously were using the opioid antagonist to save your life, they figure you're bad risk, so they don't want to touch you. So they can't do that anymore as of 2019. The electronic prescriptions, that was 2017, right after the coalition and the police department identified it as a real problem. We tried to fix that right away. We've been changing the supply of opioids. Originally, it was a 7-day supply after your discharge from the hospital. Then it was 5 days. And there is an exception if the practitioner determines that a larger supply is needed. For example, if a person has a chronic pain or a cancer-associated pain, or they're within a few months from dying, they can get the continuous painkiller. But the old custom where they would just send you home with a couple of bottles of the stuff, that is no longer the case. And that is a good thing. We also allowed prescription of non-opioid controlled substances using telehealth. So that was especially important during the pandemic. People needed a substitute to control their pain. And we started using telehealth more often, which is kind of like Zoom meetings for the rest of us, except it's done with medical. A lot of these bills come from real cases. There's another one we did with prohibiting a practitioner from prescribing controlled substances to themselves or their immediate family members. We did have real cases where people had a drug addiction in the family and they were prescribing their own prescriptions, or somebody in their family. So now you have to get another doctor to do that. Let's see. If a practitioner who prescribes an opioid drug for more than 12 weeks has to establish a treatment agreement with the patient, or discuss a care plan for chronic opioid drug use. And that means, what are your treatment goals? What are the risks of continuing to use the opioid drugs? Urine drug screening, expectations for pain treatment, and to the extent possible, non-opioid pain treatment. This one we got from, again, a program review study. We looked at one particular hospital, which was in Middletown. Which one is that, Middlesex?
Yeah.
Yeah, Middlesex. And that was the only one that was doing it. Middlesex had a recovery specialist in the emergency room with the patient. So when the patient would get through their overdose, rather than discharging them on the street, which a lot of hospitals were doing, this one hospital was hooking up the patient with a recovery specialist who was right in the room with them. And we said, wow, that's a great idea. So that's called a warm handoff. You hand off the patient to an actual counselor. And so we did that statewide starting in 2020. And the hospitals now have to do a mental health screening or patient assessment on any patient that comes in for a non-fatal. Obviously fatal wouldn't help, but if you're coming for a non-fatal overdose, now the hospital has to screen them for mental health and the assessment. Again, we're trying to link up these people before they go back on the street. We're trying to link them up with a recovery person. What else? We do patient education requirements now for substance abuse treatment programs to offer education on opioid antagonists so that they know how to come back from an overdose. We also are, I worked on this too when I was on the Children's Committee. We also are doing guidelines for the safe care of newborns born with signs of substance exposure. The exposure comes from the mother. So the child is born already exposed and suffering from the narcotics. So the healthcare providers, the hospital people, have to be involved in the discharge planning. They create a written safe care plan between the provider and the newborn's mother, and the provider has to notify DCF, Department of Children and Families, of the newborn's condition. So they flag this family that there's a substance abuse problem here. This family should be watched and helped because the child is at risk, the mother is at risk. We do share information now with other state agencies that takes care of the silo problem when one agency doesn't talk to the other. Now we are sharing information, which is always good, always a good plan. And you guys probably share with other municipalities, I would think, which is also a good plan. If there is a suspicious pharmacy or practitioner, I know we had one in Wallingford. We had two in Wallingford that I'm aware of, where there seems to be a lot of prescriptions coming out of there. I know there's a doctor in one case and a pharmacy in another case. But if there is, the drug manufacturers and wholesalers have to report if they have decided to refuse an order for a pharmacy or prescribing practitioner. They're refusing because they know something's going on. So not only do they have to do that, but they also have to tell the state Department of Consumer Protection. They have to alert the state that there's this badly practicing practitioner. And then sober living homes, which give people a chance to live under supervision as they recover. They have to have opioid antagonists on the premises. They have to train all the residents on how to use them. We did some changes on safely disposing of opioid drugs upon the person's death. And I don't know how much of this stuff you want to hear about, but there's a lot. It's a lot. I guess my point is that we have I don't know if the report is back in. We have a report going on the feasibility of establishing a court, one or more courts that specialize in criminal or juvenile matters where the defendant is an opioid dependent person. So it's basically a drug court. And these would be people who could benefit from having intensive court monitoring and being put in a substance abuse treatment program. So there's a whole as you can see, there's a whole lot of changes, and they all started around 2017. It was just boom, boom, boom. Each year we did more and more as we discovered problems. And I don't know if you want me to talk about the good news now or.
Yes, please do share the good news with us.
Okay. The good news is that we've suddenly come into some money. And that's a result of the lawsuits that the states filed against the manufacturers of the opioids. So there are a number of suits. When they are all added together, Connecticut is going to get $400 million over 18 years to fight opioid abuse and to help people who have the problem and to work on prevention. So this just happened, and the hearing was yesterday in the Public Health Committee. So what the settlement said is there has to be a council set up that decides the disbursement of the money. It has to be both municipal folks and state folks. It has to be experts in the field, and there has to be a leader in racial equity and public health. Families with lived experience. There's a lot of people on coalition that would actually fit that. And this committee is going to come up with an investment plan on how to spend this $400 million. And it's a separate account. It is not in the general fund, it's separate. And they have to report annually on the expenditures. The expenditures have to be evidence-based. And it all follows I'm trying to find it follows a plan from Johns Hopkins University on what the expenditures are. They're substance abuse disorder abatement, services, supports, and resources for prevention, treatment, recovery, and harm reduction. Public involvement in how the money is spent, accountability, and transparency. You'll be able to look up how all of this money is being spent and to which hospitals, organizations, and so on, local committees are being given the money.
That's great.
Yeah, so this just happened yesterday. This bill just came out. So
Timing.
it was perfect for today because I was
Yeah.
hoping it would be, I would get the information in time for this meeting. But anyway, that's the one thing we have not had previously is a large sum of money to help these people. And now we do. So stay tuned to that. And the several mayors testified about the misery it's caused to their town. I mean, everybody has a similar story. You could ask Wallingford, you could ask Meriden, you could ask Cheshire, you could ask New Haven. Any of the mayors would tell you that it's a miserable experience in their town and they need some help. So that's really exciting. And the other good thing was some of the players in the pharmaceutical industry that did these bad things are going to prison too. And they can't ever go into this field again as a business field. So there were a number of criminal things that happened too. But I'm very excited about the money, so stay tuned with that. I'm assuming this bill is going to pass, and then you'll watch the committee form, and then they will start to decide how to deliver the money to the towns, and you should definitely pay close attention to that. And if you see they're not doing something, you should say something about that. But it's very hopeful. I'm really very excited about it, and I think the bill will go. And I want to thank Attorney General Tong for suing these people because that's how we got the money. So, yeah.
Thank you so much. Thank you so much.
It's really great to see that we live in a state that, again, just like our medical professionals, everybody really has a stake in addressing this problem. So the last question that I have, and I would like each panelist to kind of give their insight on this. And then I think we have time to open up the floor for questions afterwards. So what can we as a community be doing to keep OUD relevant and in conversation? And, you know, I feel like with our media, right, things ebb and flow, but I feel like this is something that's so important that we need to keep in conversation. So what advice do we have?
So staying abreast of what's going on, as we just heard about the money that's coming into the state and how it's going to be used, but understand things such as naloxone is an opioid overdose reversal medication that's safer to use than aspirin or Tylenol. And anybody can be trained to use it. The more of it we get out in the community, the more lives are going to be saved, the better chance we have of getting people into treatment. Understand that programs exist like the MORE program in Meriden, where first responders, if they come on someone that has overdosed, they connect with this team. It runs out of Rushford. It's done with the city of Meriden. And on the team is a clinician, a recovery support specialist, and a coordinator, and they will come out and meet with that person. If they don't want to go to the hospital, if they don't want treatment, they'll engage them and they can work with them. We've had a lot of success in getting people, first they get their needs met, their basic needs, but then they may be more interested in treatment, and a number of them have converted to more traditional treatment. So that's a really important program, and those kinds of programs exist. Make yourself aware of those programs. Understand that opioid use disorder and all substance use disorders are chronic diseases, just like chronic obstructive pulmonary disease, COPD, hypertension, diabetes. These disorders don't necessarily go away. They need to be monitored for long periods of time. There are lifestyle changes, there are diets, there's exercise, there's nutrition, and there's medications. And for opioid use disorder, know that the evidence-based approach that decreases opioid overdose deaths is using medication for opioid use disorder. There are 3 medications that are FDA approved for opioid use disorder. 1 is methadone. 2 is buprenorphine-based medications like Suboxone. And number 3 they're called antagonists. They work a little different than the other 2, which are agonists and partial agonists, and that's naltrexone. And those are the 3 medications that are approved for opioid use disorder. They decrease the your chance of dying from an opioid overdose by greater than 50%. And that's one thing that we know. First line treatment, know that that's true. That's what you can do. Know that that's true. Know naloxone saves lives, and understand what kinds of programs are available out there.
And I want to hear from the officers, because they're the ones who can help the whole community, help you to curb the incoming sales of drugs in here. And I know Ken Welch, who's not here because he's still recovering from his accident.
I think he might be here virtually.
Maybe he's here virtually. But Ken has always been a person who's perfectly willing to pick up the phone and tell you guys, I see something going on right here on this street at this time, and then you guys would come down and deal with it. And people have to be willing to do that. If they see something bad for the community going on, they have to be willing to make that call. So I hope people will follow the legislation. If you do want to track it from your house on your computer, it's Bill 5044. And this is the one which will determine how this money is spent to protect people. It's in the Public Health Committee. And if you go to ct.gov, that's the state website for Department of Mental Health and Addiction Services. If you go to cga.ct.gov, that's the legislator's site, and then you could type in the bill number 5044, and you can actually see where it is and read some of the testimonies from people that have lived through this. But I did want to leave one number here just to remind us how important it is that we all participate. this is just from the year 2020, which was a bad year because of the COVID pandemic. People were more willing to use opioids that year. In the pandemic, they were isolated, and it was we lost more people. But there were 93,000 Americans who died that year from opioid overdoses. That is the most ever in a single year, and it's more than died from either car crashes or gun violence. So 93,000, that's a serious societal problem, and everyone will have to help with this. But I am hopeful today because of the funding that I think we can use right away, and then you can tell us what we can do locally. Thank you.
So yeah, for the first portion of it, I think what the community could do is just be educated on the situation, on that there's resources out there that you could search and figure out how you could better understand the problem. I know even for officers, there's always trying to educate themselves on the issues that are going on, especially with opioids. There's a lot of resources available to where you could kind of guide somebody if you have community, family, friends who are having issues with this and you don't know really what to do to kind of get them this information. Like Department of Mental Health and Addiction Services is a great resource to kind of figure out where you want to go from there. Our aspect as law enforcement, we really show up when it's at the worst moment for the person. So the medics sometimes get there right as we do or a little bit later. So when we're dealing with the subject, if they have overdose, they're not going to be too responsive to us when we get there. So we give them Narcan if we have to get them out of their medical issue. And then once they get out of it, they're kind of still not all there. So they're getting treatment. But what we do is try to figure out where they're getting these opioids that are causing them to have this effect on them. Because a lot of people we do deal with, it's not the first time. So they've been using for a while. So what is causing them to kind of go into this overdose situation? Now it's going to come back to where they're getting this drug, and if it's cut with something more lethal, which has been in the has been happening, where are we getting this from? So what we do as law enforcement, we reach out to other agencies, this state, other states, see if we could kind of figure out, because sometimes these dealers do mark their stuff, so we could try to pinpoint it to a certain person who's dealing. It's a lot of investigative work. That's why you have to work with other agencies who are bigger than us. So, Connecticut has a narcotics task force. We have the DEA. There's a whole bunch of task force going on there. So the investigation part is trying to track down who's supplying this stuff. And then you keep your investigation leads from there. I know through my career, the 17 years I've been here, it's obviously has increased as of recently. It's also, I know we have school resource officers that we try to have them run some programs in schools to try to educate the children on the effects of this. We have also the youth and social services that we do send some of these students who are having issues with other types of drugs, so it doesn't kind of escalate into anything else. But I think to go back to the original thing, the community is just understanding that is a problem, which also these types of individuals who are having substance abuse issues, they do commit other crimes because they're looking for money. So we see increase in shopliftings, larcenies, and crimes of that nature. And a lot of times it could be tracked down for somebody who's having substance abuse issues and they're just trying to get money to get their next fix, so to say. So it does kind of evolve into other things. So we're just trying it would benefit everybody if we could get these people the help that they need. And that help is going to be at a different level than the local law enforcement. That's the main goal.
My surgeon hit on most of it, but just a couple of things. Just remember, the Good Samaritan Law. A lot of people wait to call, or they don't think to call because they're scared that their friend or relative may be arrested, or that they'll get in trouble because they had that individual in their home or in their car or wherever they are, and an overdose or drug activity may happen. And just the base of it is safety is paramount, and we're not going to go and arrest anybody for doing the right thing and getting their friend or their relative help. So if you think drug activity is happening, or you come across them shooting up or sniffing or whatever they may be doing, if you find them overdosed, don't wait, just call, because time is of the essence at that aspect. If they are in the midst of doing drugs, unfortunately, sometimes people are scared and they don't want to call. And by the time we get there, it's too late. So always call. Don't have a fear of someone getting arrested or in trouble. That's not why we're there at that point. At that point, it's to help the person who needs the help. And then another thing is, as was stated before, if you see things that are suspicious, we are proactive and reactive as a department, but a lot of the time we don't know something's happening if we don't get a phone call. We can't be everywhere. So if you see what you think is a hand-to-hand or a drug deal happen, or you see cars lingering that you don't recognize, call the department, let us know, because we'll pay extra attention to that area, or we'll do constant drive-bys, or we'll do an investigation. So without the help of the community telling us what they see happening on their streets or their neighborhoods, we may not know, because as I said, we can't be on every road at all times. So it's good to have the community also helping. It might be nothing, but it could be what you think it is. So always reach out if you see anything that you might think is, importance when it comes to, police investigations and drug activity.
Thank you so much. And Ernie, our final, you can take it home, Ernie, whatever you think we can, the community can be doing.
I just have two issues, one for general information, and that's the Drug Enforcement Administration put out a drug fact sheet, counterfeit pills. This has been going on for decades, but they've gotten a lot better. I'm looking at a picture of Oxycontin 30 milligrams, and I side by side with the illicit one with the fentanyl in it. I'm looking at an Adderall tablet, 30 milligrams with the illicit one. I'm looking at Xanax with the illicit one. The point is that fentanyl is in disguise in these tablets simply because it's a white powder. And they're mixing it with heroin, which is a white powder. They're mixing it with methamphetamine, which is a white powder. They're mixing it with cocaine, which is a white powder. And they're marketing on the internet as the respective brand names or generic names. So the issue is that just don't go on this internet and think because it's cheaper, you're not getting the real McCoy. These are coming from places like the Bahamas, Eastern Europe, Africa, all over the world. And because it's easy money to be made. The second issue is you may have a drug dealer in your home. And what I'm speaking of, I got some recent articles this year alone on social media and how teens and young adults have accessed certain sites on social media where drug dealers are pretty crafty in promoting them to sell them these counterfeit pills. So for the parents out there, make sure you know what your child is doing. And there's been a national survey that says that teens spend more than 7 hours a day in front of a screen outside of schoolwork. So just be careful. They have their own slang. Just as drug dealers and addicts have their own slang to describe what they're talking about with their friends. And that's it.
Absolutely. And to that point, on our coalition Facebook page, we actually have a resource from DMS maybe, and it actually shows you the emoji combinations that kids use on their phone to denote certain drugs or certain deals. So kids are smart. They know how to code things. They know how to create their own language. So we have those resources on our website. So if you ever see, I don't know what they are off the top of my head, but they have very specific emojis that they use to code their language, which is alarming. So I on Ernie's last note, I would like to say thank you so much to all of our panelists for taking the time to come talk about a problem that I think will unfortunately be a problem for Lord knows how long. But I am so happy to hear that there's so many people just in this room alone who really care enough to really take the time to keep it in the conversation. One thing I'll note, the Coalition for a Better Wallingford is right in the center of town. You can't miss us. Right now we have a giant Olaf on our window from Christmas time. So that's where we are. We always have Narcan available at the office. So if you need Narcan, personally, I carry it in my car for these community potential situations. I've got my own people in my life that use, and so I want to make sure that I am prepared for any situation. So if you ever need Narcan, please come talk to us. And if you ever have anybody who's in a situation in which you need resources, come see us and we will point you in the right direction. Awesome, great.
One was a question for Ernie. You were talking about visiting different places, and Jeff asked how you visited veterinarians as well in the visiting you've done.
Interesting. I don't know if you heard that, Ernie, but there was a question for you in our ADOPS training, if we've thought to visit veterinarian offices in our different stops.
No, what we did, well, this was due to the grant. We went to all primary care physicians and oral surgeons. We also went to all 5 pharmacies in Wallingford and see how they did prescription drug monitoring. You have to realize, though, we're still in the COVID pandemic. So it was hard to get an audience with physicians or nurse practitioners, physician assistants, and ask them these questions. But we managed. They were, you know, got to talk fast and whatever, because they're usually with patients. So, and that kind of thing. But no, we didn't visit veterinarians.
Oh, what a great point, right? That is a great point.
And Ken did appear in the chat.
Awesome.
Ken would like to say that everyone needs to deal with their own piece in every way. That's why the panel was put together in this fashion. It used to be a problem with 5% or less of a community facing addiction has changed. This can affect up to 40 or 50% of our society. We all need to own it and do what we can. Thank you.
Absolutely.
So thank you all panelists. I learned so much tonight. Really appreciate being here. I'm Jane Fisher. I work here at the library. You answered one of my questions, Jesse, which is how to get Narcan. So we have it in our first aid kit here. We've administered it here. One of our staff members has administered it, and the dose that we have remaining is expired. So I will come down to get some. But I think it's been a couple of years now. We had some training here for the general public on how to use Narcan, and it might have been somebody from the state who conducted the training and gave out Narcan to everybody who participated. We'd be interested in hosting that again if there's a resource to do that here.
Yeah, absolutely. We are happy to help facilitate that. I'm happy to report to, I believe in the Wallingford Public School System, Tony Loomis informed me that they are also doing an Narcan training there, which I think is great. So we're kind of helping with that, but yes, we can definitely set up a training here at the library. There's also monthly virtual trainings that are held through VH Care. You can't necessarily pick up Narcan, right, because it's virtual. But you could always come to the office. We do advertise those on our website and our Facebook page. So if anybody ever wants to attend a virtual training, that is an option. But we would definitely love to do an in-person training. We have a trainer who's available, so we can definitely offline coordinate that because I think it's super important. Absolutely. Any other questions?
I'm really pleased to hear that obviously I was aware of the coalition making Narcan administration available and recommended to people who needed it at that time. And I'm also very pleased to hear Jane saying that the library actually has that in their emergency kit. I'm a retired dentist, and in our offices, many of us will have our AEDs. And many of us who've retired bring the AED home with us. Okay, so that we may have to use that for a neighbor.
Sure.
We've taken Red Cross training for compression training. And that has almost become, if not mandatory, it's spiritually required for a healthcare practitioner. And those of us who are retired, I drive around with aspirin in my console for people who may have an issue that needs immediate, at least relief. We think whatever that was, it happened to me down at the local Y. And lady, healthy. Did it help? I don't know. It made she feel good. She felt a whole lot better ultimately. But there was a thing that happened in the I read in the newspaper recently about a healthcare provider, not a healthcare provider, but an emergency provider who was administering to a person who required that help, but they themselves became involved as requiring services because of the medication that was being. So apparently, we ought to have, as civilians, interested civilians, we ought to have some degree of education in the and recommendation, perhaps, that we do reach out at a moment's notice in church, Stop and Shop, wherever you happen to have it. I don't know how portable it is, but it seems to me to be reasonable. Essentially, got plenty of bucks.
It's very portable. People carry it around in their pockets.
Yeah.
And you're much more likely to come across someone who has suffered from an opioid poisoning than you are someone who's had a cardiac arrest. So we have the AEDs. Those are potential, you have to know how to use those. You have to, don't have water on your hands and take your hand off of the person's physical body before. Naloxone is safe to use, very easy to use, very quick, and you carry it around in your pocket. I carry it with me all the time. You carry it around. Wonderful to hear that the library administered naloxone, and you guys have it. Anywhere there's a bathroom, someone might be using. Anywhere there's a place to hide away. So that's great. It's nice to hear about the interest, and I agree with you. I think that everybody should be exposed. It's a simple thing to do, and it could potentially save someone's life. We don't have that kind of opportunity all the time. It's a great opportunity.
Yes.
About 25 years ago, in order to get your driver's license in Germany, you had to be first aid certified. And you were required to stop and assist anybody that you saw.
Wow.
With a Good Samaritan type
Yeah.
of there.
That's amazing. That would be good, right? That would be an amazing thing to implement here.
Besides your donor thing and your license, yeah, not can or something.
Yeah.
Another question.
Okay.
Are any hospitals or clinics in Connecticut offering clinical trials using psychedelics to treat opioid addiction?
No. I was on the state work group looking at psychedelics. Actually, it was psilocybin assisted treatment. We just completed and submitted our report, and I think that, yes, that's coming up. The bill's coming up. The report's coming up sometime this week. So I'm hearing that. Public health, yeah. And so it's psilocybin and other psychedelics have been used for alcohol use disorder. They do show promise, certainly for depression and post-traumatic stress disorder. But in the state of Connecticut at this point in time, there's no research on opioid use disorder that I'm aware of with psilocybin or any other psychedelics. But there are studies looking at alcohol use disorder and some other substance use disorders. It'll be interesting to see it.
Any other questions from the audience?
I just want to mention one thing about him
Yes.
because he's not here.
Yes.
And he would be. Folks, he's technically, but he was injured in a snowmobile accident. And despite that, and despite being in pain and having a collar around his neck because he had broken something in his neck, the lottery signed him up as 147 in the public hearing. And I said, just send it in, Ken. You're 147. They're never going to get to you. He stayed up the whole day into the night to speak in person because it was so important to him. Even though he was miserable and he was number 147, he still stuck it out and he testified. So that's truly dedication. And I hope he gets what he wants after suffering that long to be a witness.
Absolutely.
Ken really does what he practices, what he preaches, and he sticks it out for as long as it takes.
Absolutely.
Absolutely. Ken is amazing for those who haven't had the chance to meet him. He is dynamic and wonderful and a great speaker. As you can see from his comment, even his comment was well written. So if there's no other comments or questions, I think we are all set. Thank you again for a dynamic and great conversation. Thank you for taking the time. I will stick around for a little bit if anybody has any questions. Stay safe. It's supposed to snow tomorrow. So good luck for that and have a lovely evening. Thank you.